So, Matt, I have a few comments to make, and then I'll turn it over to you. As I mentioned in my comments yesterday, the Office of the the U.S. Office of the National Coordinator for Health Information Technology, also known as ONC, supports a number of projects for LOINC and the Health Data Standards team. We're going to hear remarks from them, and our presenters are Vaishali Patel, Chelsea Richwine, and Matthew Rahn. And I believe they're ready, and I'll turn the floor over to our speakers.
Thank you. Appreciate that. Hello, everybody. I guess good afternoon. It is the morning in the U.S., but I'm sure there's folks all over the world looking at this, but you're all in lovely France, I think. So thank you for having us, Marjorie. Appreciate that. So I'm going to be fairly brief and give some overview of some of the projects that we've been working on with the LOINC team at Regenstrief and other projects that are aligned with that work as well. And then I'm going to turn it over to Vaishali and Chelsea, and they're going to talk about a survey that we had done around LOINC usage in the U.S. Next slide. So quick overview about ONC. I'm going to talk about a few of the cooperative agreements that we have with the LOINC team, the regulations that require certified health IT, and the LOINC standard. Next slide. So again, thank you. I'll just say, I guess I didn't really introduce myself, but I'm Matt Rahn. I'm the Deputy Director of the Standards Division at ONC in the Office of Technology. And ONC was founded in 2004 via executive order and established in statute in 2009 via the HITECH Act. So we're charged with formulating the federal government strategy for advancing the national goals for better and safer healthcare through interoperable nationwide health IT infrastructure. And how that was set was via HITECH Act in 2009. There was a sizable investment into CMS to subsidize EHR systems in hospitals and ambulatory providers. And what came with that was a ONC certification program. Fast forward to 2016, the 21st Century Cures Act was signed into law, which added some requirements around definitions for information blocking and the access, exchange, and use of EHI. And with that also required access of information through an API without special effort. Via the most recent Cures Act final rule, we did require an API standard, the Fast Healthcare Interoperable Resources, FHIR standard. And we also, in that law, required a nationwide governance for HIE networks, so what is formerly known as the Trust Exchange Framework and Common Agreement, TEPCA. Next slide, please. Yeah, and I think I'm just seeing that come in. I think there will be probably some time at the end for us to, have some questions. So what are ONC's focus areas? We have three primary areas of activity that, along with our coordination efforts, are intended to further our ONC's objectives to advance the development and use of health IT capabilities and establish expectations for data sharing. Some of those activities are around standards, certification, exchange. In the standards space, we coordinate and invest and promote programs and policies that lead to greater consistency of how health data is represented, specifically with the work I'm going to talk about in a little bit with the Regenstrief team and what Chelsea and Vaishali will discuss. The second thing is certification. So ONC administers a certification program for testing of health IT to specific technical baselines and oversees how developers of certified health IT participate in the market. And the third thing is exchange. So we coordinate, invest, and develop and promote programs and policies that expand and improve the secure transmission of electronic health information. And then you see in the middle there, the coordination piece. The key part of ONC identity is the coordination piece. And I'll speak a little bit to some of the more recent work that we've been doing around we call the USCDI Plus. But we do coordinate with a range of stakeholders: government, non-government, federal, state, local, public, private, for-profit, not-for-profit, to help progress towards those two objectives of advancing the development and use of health IT capabilities and establishing expectations for data sharing. Can you go to the next slide, please? So, as I mentioned, the EHR certification program, it was officially established in the HITECH Act. It is voluntary, electronic health record program. However, via CMS, Centers for Medicare and Medicaid Services programs, it does require the use of certified health IT. So while it's voluntary, EHR vendors must certify their products. And we do have certain criterion within our certification program specific to electronic lab reporting for public health where LOINC codes are used. And I'll talk a little bit more about USCDI in the later slide, but US Core Data for Interoperability version 1 is in our Cures Act final rule regulation, and the implementation of those specific data will be required by the end of this year, and they do include specific requirements around LOINC standard. Next slide, please. So, as I mentioned, we have some cooperative agreements with the Regenstrief team. One is a general cooperative agreement that we've had in place for a few years now. And during COVID-19, we did receive some CARES Act funding that we used to support them. And I'll talk a little bit about the work we're doing with the regular cooperative agreement that has just ongoing support for increasing the use of LOINC standard in healthcare information exchange by expanding the content and how to improving the content use. So, we want to ensure that each data element specified in what I mentioned earlier, the US Core Data for Interoperability is provided with the provided LOINC codes, appropriate LOINC codes in a timely manner. So we do help support the work they're doing to make sure that the correct LOINC codes can be available when we put out a new version of the USCDI, which I'll give a little bit more info on in the next slide. But then the other thing is we want to make it easier for people to find LOINC codes that you need and navigate around the LOINC website. The hope is that these improvements will help facilitate the increased use of LOINC. And from like a technical infrastructure standpoint, we want to be able to perform necessary software enhancements to existing tools for health information exchange using newer API-based standards, and then upgrading the Regenstrief LOINC mapping assistant, aka RELMA. So those are kind of the ongoing support that we have. And can you go to the next slide? I'll speak a little bit about the COVID-19 cooperative agreement. So during the pandemic, we realized that there was opportunities to help improve on a few things. I apologize, the sun's coming behind me and I have my window open, so if you can't see me too well, I apologize. But so what we wanted to do was prioritize the creation and mapping services for COVID-19 testing and other public health needs, as well as any infrastructure to support the COVID-19 and other public health terminology development interoperability. And then, make sure that we can expand and improve the adoption of terminology standards. So there was some overlap that we had with the previous one, but this was just additional opportunity for us to help improve the adoption and interoperability of the LOINC standard. Next slide, please. Can you go to the next slide, please? Taking a second. Thank you. So, and I mentioned this before. One of the requirements that came out of the Cures Act final rule is what we call the United States Coordinator for Interoperability. This is previously had a name called the Common Clinical Data Set. This is just the standard minimum set of data that must be exchanged and used for interoperability in the United States. It requires specific data elements and vocabulary standards. So, there'll be specific data elements that then require a applicable vocabulary standard to them. It is agnostic to format, so we have it in multiple of our certification criteria. So in general, it is used with CCDA, Consolidated Clinical Document Architecture, and HL7 standard, and FHIR, as I mentioned earlier. This is a standard that's updated on an annual cycle with input from federal agencies and general public. There's a bunch of different criteria that go into how it's updated, and that's including standards maturity and public and industry priority at the time of when we are setting a version. So we are currently we released in July version 3. So USCDI version 1 is required in regulation. USCDI version 2 is also an option via something that we put in the Cures Act final rule called the Standards Version Advancement Process that allows vendors to move to a newer version of a standard that the National Coordinator of Health IT names. And we just released version 3. That will be up for adoption potentially in the June cycle of our Standards Version Advancement Process. But that process just allows us flexibility to move on to newer versions rather than being set super far back. Next slide, please. And as I mentioned, there is LOINC is required for certified health IT modules when exchanging specific use cases, specifically around laboratory results, clinical tests, diagnostic imaging tests, SDOH, clinical notes, health status assessments, and vital signs. So when you see this in, I can put some, after I'm done and I turn it to Vaishali and Chelsea, I'll put in some links into the chat that will take you to USCDI, and you see like the standard itself. You'll see laboratory results, and next to it, it'll say the required LOINC version. In general, it might be an older version, but you're always able to move to the newest version of LOINC to meet the requirements in that certification criterion. But it is something that we require in the U.S. For multiple different data that we capture in our EHRs. Next slide, please. And quickly, I did mention this earlier. We've about a year ago, we were realizing that there were certain things in the with our federal partners that we may not have been addressing, and so we created a service to collaborates with our key stakeholders in the federal government and their key stakeholders. So, for example, like CDC, they would have the state, local, tribal stakeholders participate. But what this does is it goes above and beyond what we require in USCDI, the version 1 standard, and we establish and harmonize and advance use of interoperable data sets that extend beyond the core data in USCDI to help specific agency programmatic requirements. For example, we are currently working with the Health Resources and Services Administration in the U.S., which is a sub-agency of HHS, and they fund community health centers, and they have a reporting program called the Uniform Data System modernization effort that we're working with them on what they call UDS Plus. And that is data sets that is above and beyond just the USCDI version 1. And so at some point in the future, their stakeholders are going to have to do their reporting, hopefully via FHIR, and they'll have an implementation guide that's similar to what USCDI version 1 looks like. But the whole goal is to collaborate across our federal partners and the community and create these data sets that will be useful for a specific use case and adopt them in real world. And some of those specific to this, there could be some, specific LOINC codes that need to be created that we would, through our cooperative agreement, work with the Regenstrief team to create and then ultimately implement to ensure that the standards are aligned across the federal program. So with HRSA, we're also working with Centers for Medicare and Medicaid on their quality measurement reporting. And if there's any overlap, we make sure that there is some alignment there. So we're not creating multiple different implementation guides that aren't in alignment. But this is something we've been working on over the past year, currently working with the Centers for Disease Control, the Health Resources and Services Administration, and the Center for Medicaid and Medicare and Medicaid. And we are still talking with other agencies, and hopefully you all may see some implementation guides that come of this. It's still early on in the process, and still working with the federal agencies to get to a place where we'd be able to share more of that publicly. But happy to answer any questions on that after Vaishali and Chelsea go. But that's all I have today. Thank you. I will turn it over to Vaishali and Chelsea. They've got the more fun stuff that we've been working on with the Regenstrief team. So thank you both, and I'll stay on for questions later. Thank you.
Great. Thanks, Matt. My name is Vaishali Patel, and I am the Deputy Director of the Technical Strategy and Analysis Division within ONC. And Chelsea Richwine is a health economist and researcher who is in that division. And today we'll be talking about lab interoperability and the use of LOINC among US-based laboratories. And we'll be presenting some preliminary findings from a survey that is still in the field. So if you're a US-based lab and you haven't participated yet, please do so. But we're gonna just talk a little bit about just lab interoperability and just share some kind of tidbits or preview from the survey. Okay, so why lab interoperability? As Matt mentioned, ONC focuses on interoperability of many different kinds of data. But we have put a special focus on lab interoperability because in part of the clinical implications of lab data. And, I know I'm speaking to experts in the field, and you probably know all of this, but, in terms of why ONC has focused its efforts, it's because, lab data is known to influence, many medical decisions, and some studies, they cite up to 70% of medical decisions. And, there are billions of lab test results that are ordered annually within the United States. And the speed and accuracy of those billions of laboratory test results is really essential to medical care and public health. And so interoperability, which really has the potential to enhance both the timeliness and accuracy of laboratory data, is, a real focus for ONC, because in part by improving the interoperability of laboratory data, it might lead to improvements in patient safety, through having structured laboratory data that's available for use in clinical decision support alerts, reductions in preventable diagnostic errors, also reductions in redundant tests and increases in efficiency. If one is able to electronically exchange data and not have to order multiple tests, because the laboratory results are available from a prior test. The interoperability of laboratory data can also enhance the quality of care, because if timely data is available, those medical decisions that are influenced are more likely to be informed by the test results. And it also enables care coordination through sharing of test results across settings and systems. And as we know, like during this pandemic, having laboratory data available for public health agencies is really critical, so they can respond appropriately to pandemics. So I think before we go into the survey, one thing we wanted to just briefly highlight was just the laboratory context within the United States. I know there are a lot of participants from many countries, and the context may be different. So this might be helpful just to understand what the context is in the US. And so this table here presents different types of laboratories within the United States, and the percentage of labs that are of that type based on the number of labs, and then also based on volume of test results. So as you can see here, hospital laboratories and independent laboratories make up a relatively small percentage of laboratories in the US if one looks at it based on just the number of laboratory sites. However, they process a very high volume of test results. Over close to 70% of test results are come from hospital and independent laboratories. In terms of if one looks at it by volume, there are many smaller laboratories in the United States that are based in physician offices, about 37%, but they only account for less than 10% of total number of volume based on volume of tests. And there are also many, like a diverse set of laboratories that constitute about half of laboratories in the US. So based on, that might be located in schools, residential care facilities, and the like, but they make up, again, only about 10% in terms of volume of test results. So in the United States, the last national survey of independent and hospital laboratories that was conducted was back in 2013. So, more than a decade ago. And at that time, we found that about overall, across both the hospital and independent labs, about 6 in 10 possess the capability to send structured test results electronically. And there was definitely variation between hospital labs and independent labs, with hospital labs having a higher percentage that had the capability of sending test results electronically. About 7 in 10, you could see in the graphic on the left, about 71% compared to 62% of independent labs. So that, that overall was good news back in 2013. A majority of labs possess the capability, but when we actually looked at, how many of those labs were sending a majority, so 3/4 of their test results as structured data to their ordering practitioners' EHR systems, that dropped dramatically to about 3 in 10 hospital and independent labs sending more than 3/4 of their test results as structured data. So there was a big gap between capability versus actually sending those test results electronically in a structured format. And the variation in capability really, there was also variation within here, not only by hospital and independent labs, but also by size, with smaller labs, within hospital labs as well as independent labs having lower rates of capability. But we know very little about how we've progressed since 2013. And we're going to have Chelsea Richwine is really going to, she's going to talk about this new survey that we are embarking on in the middle of. And I am going to hand it over to her.
Great, thanks, Vaishali. Yep, so I will present some of our findings and an overview of the 2022 Lab Interoperability Survey, which we are currently in the middle of fielding. The aim of this survey was to understand the use and implementation of LOINC among US-based laboratories. This work can help inform LOINC's future technical and terminology development processes, as well as HHS's efforts to improve lab interoperability in the US. We also aim to identify barriers to using LOINC for specific purposes, such as issuing orders and reporting results, in order to understand some of the factors that may be hindering adoption and use. So the target population for this survey included all US-based certified CLIA laboratories, so the Clinical Laboratory Improvement Amendments, which is a federal program responsible for laboratory oversight in the US. As I mentioned, the survey is currently in the field, so it started in August 2022 this year, and it will remain open until the end of the year in December. So the findings I'm going to present today are a preliminary cut of the data, which were pulled at the end of September. So we still have a few months to go to keep these data rolling in. It's also important to note that in this survey, points of contact, so the respondents for the survey, were asked to respond on behalf of all lab locations that they oversee. So responses may reflect one location or multiple lab locations, depending on the respondent. Next slide. So Vaishali already showed you the different type of labs in the US. For this survey, we wanted to focus in on hospital labs, given that they produce a large percentage of the lab volume. Next slide. So this figure shows a hospital lab ownership among the respondents. The majority of them, about 61%, were not-for-profit owned, followed by government owned, and the remaining percent were various for-profit owned. Next slide. And this figure shows the hospital lab volume. In the survey, respondents were asked to indicate the total number of test results labs sent to ordering practitioners or the Centers for Disease Control during the 2021 calendar year. So we can see that most of the lab volume for hospital lab respondents were under 1 million. Next slide. Now this figure illustrates the percentage of test results by volume that were sent in an electronic structured format by hospital labs. So this finding is encouraging because it shows that 76%, so 3/4 of labs, indicated that their test results were usually or always sent in an electronic structured format. Next slide. However, when asked about complex lab results, only 20% said that complex results, such as those for clinical genetics, were sent in an electronic structured format. However, it's worth mentioning that 36% said they didn't know. However, among those that said they did send complex results, 80%, so most of this group indicated that LOINC was the most commonly used system for sending complex results. It's worth noting that these figures won't add up to 100 because they could select multiple coding systems. So in addition to LOINC, 34% indicated they used SNOMED CT and 29% used another coding system. Next slide. So among those that indicated that they didn't send complex results, there were various reasons noted for not sending results in a structured format. Among those, some of the most common were their EHR system was unable to receive structured results. They indicated they didn't have the resources to implement structured result reporting, or that the structured format was difficult to set up and maintain compared to unstructured formats. Next slide. So in this figure, although the survey was largely focused on LOINC, we also looked at those who use SNOMED CT for reporting qualitative lab results. SNOMED CT is in the HL7 specifications for qualitative result values and listed in the US CDI as an applicable vocabulary standard for qualitative lab result values. So we looked at this as well and found that only 17% indicated that they use SNOMED for reporting qualitative lab results. But worth noting again that over half indicated that they didn't know. Next slide. So in addition to use of SNOMED, we looked at the use of LOINC for issuing orders and reporting results. So these findings are reported side by side in this panel. And we found that hospital labs indicated that about 23% indicated that they used LOINC for issuing orders, and 41% used it for reporting results. So here we found that LOINC usage was much more common for reporting results, about twice as high the rates were for results relative to orders. But it's worth noting again that the share indicating that they didn't know was relatively high, in fact, higher than those who said they did not use it for reporting results in this case. Next slide. So again, among those that indicated they did not use LOINC for issuing orders or reporting results, there were various reasons indicated for not using it. And they were in alignment for both. In other words, there were common challenges, such as not having the resources to map or maintain those mappings to LOINC. Some labs indicated that LOINC codes were difficult to use. In addition to not knowing what LOINC was, there were some that said they had the capability to use LOINC, but they used a different laboratory coding system already, or that LOINC could be implemented, but the cost outweighed the benefits, so didn't have an incentive to use LOINC. Next slide. So some of the key takeaways based on our preliminary findings was that thus far, a majority of hospital labs indicated that they sent 3/4 or more of their test results in electronic structured format to ordering practitioners. However, fewer labs indicated that they sent complex results in electronic structured format. But encouragingly, most labs that did send results electronically used LOINC to identify the test. Some of the common reasons for not electronically sending test results related to the recipient's EHRs not possessing the capability to electronically receive results, the lack of resources or perceived difficulty of setting up and maintaining those structured results reporting, as well as the lack of capability of the laboratory information systems to support LOINC. Additionally, about 1 in 5 hospital labs use LOINC for issuing orders, and about 2 in 5 use LOINC for reporting results. So here we found a similar set of barriers limiting both electronic exchange of data in the first set of takeaways, as well as the use of LOINC more specifically. So again, lack of resources or expertise to map or maintain those mappings, lack of awareness of LOINC or perceived difficulty in setting it up. And a lot of labs indicated that they already had another coding system in place, which for that reason, they may have found that the costs associated with adopting LOINC just didn't exceed the benefits. Next slide. So the next step for our analysis and for the survey would be to ultimately look at the same set of questions with the finalized data, which we will have in December, So again, these are preliminary and they may change as data collection continues. So we plan to look at these questions not only for hospital labs, but for the various types that we are looking at in the survey. So please, if you are a US-based laboratory, please participate in the survey if you haven't already. The more responses we get, the more representative this will be. And ultimately, once we have this data collection complete in December, we will share a summary of our updated findings to help inform policy, as well as LOINC Regenstrief's efforts to encourage the adoption and use of LOINC. So I will stop there, and we can pass it along for any questions for Vaishali and I or Matt. Thank you.
Thank you very much. Chelsea, Matt, and Vaishali, thank you for that. Are there questions from the room? Can't hear you.
This is Clem McDonald. Two pieces. One, I'd like to for Matt, who didn't have a special question answering part, I'd like to compliment him on the work he's done by encouraging the improvement in the LOINC querying system. It's really wonderful, the new system, which is Search LOINC, compared to RELMA. So thank you, Matt, for that work. And this surveys thing, thank you also. It's wonderful. I mean, it's going to be very informative, and we look forward to the final results, and glad that you're doing it. Thank you.
Thanks, Clem. Really appreciate it. It was a lot of work, to be honest. The survey was, I'll say. So I appreciate it.
Yeah, and thanks to the Regenstrief team as well. Team effort.
Yeah, totally.
Thank you. Other questions from the room or online? Tim Benson.
I've got a question. What lab specialties are you covering? Is it all of them, or including anatomic pathology, for example, or is it? That's the first question.
So sorry, is your question in reference to the laboratory survey?
Yes, you mentioned lab reports, and do they cover everything that happens within all sorts of pathology laboratories, or is it just the hematology and chemical pathology, or is it?
Yeah, we did not exclude anything. So we didn't specifically ask about anatomic pathology. I see Andrea has a question in the chat. We didn't, specifically ask about different types of lab tests or anything like that. We asked about it very broadly. So, and happy to share. We can also share a copy of the survey instrument. Once, as part of, when we summarize the results as well.
Thank you. Vaishali, is there a question
Vaishali,
online? Oh, go ahead, Matt.
No, I was just going to say, is there a link to how they could participate in the survey still, or?
April or Jennifer, I'm looking at our Regenstrief partners on that, that maybe we could share a link.
Hi, this is April with LOINC Regenstrief. Right now we have it set to a particular distribution list. So if you would like the survey, I would suggest emailing us at loinc@loinc.org.
Okay. Any more questions? Was there one from Andrea? Okay.
Yeah.
Here, I can read it.
This is Clem McDonald again. I'd like to comment on how effective and important ONC's work has been in improving interoperability. I mean, I think it's over the last 7 years, it's really been dramatic, and I applaud it, and I hope you guys can continue the good work.
Thank you. Elizabeth?
Okay, question from Andrea. She says great presentation.
We can't hear you.
Sorry.
Get closer to your mic.
Great presentations. Excited to see final results. This is great to inform about current state and what is most needed to help labs. Does the survey cover anatomic pathology?
So Vaishali, Matt, or Chelsea, did you hear that question?
Yeah, I did, and
Okay.
I guess what I'm saying is we didn't exclude it, so
It's
you
hard
know,
to extract
yeah,
it then.
yeah, we didn't exclude it, but we didn't ask specifically about it. So I don't know if that helps, but
Any more online questions? No. Any more questions from the room? Oh, Tim Benson again?
I have a second question for Matt, really. He mentioned the work being done on social determinants of health. Is that based on individual patients or is that based on a location? Or both? Or what is it about?
So, USCDI is definitely focused on the two different, like patient care and then the population health. We do have different criterion that apply to both situations. And if you go to the USCDI version 2 and to version 3, you can see some of the specific data elements that we will at some point potentially require in a either a new regulation or via a standards version advancement process. So, there's SDOH assessments, there's SDOH problems, health concerns, and a few others, SDOH interventions. But there's focus on patients and population level data. I don't know if Vaishali has anything she wants to add to that, or Chelsea.
Okay. There being no more questions or comments from Vaishali or Chelsea. There are no questions in the room. This concludes the session. Clem, did you have another comment?
No, I'm just standing up.
Okay. All right, so this concludes this session, and it is the last session of the day. It's been a great day. Get out and enjoy beautiful ONC, and we will see you tomorrow at 8:30 a.m. Thank you.
everybody.
Thanks, everyone.